All right, let's talk about congenital defects. So, the first place to start is you need to review normal blood flow through the heart. I've put a JPEG here on your slide and also in your outline. Be sure you've got your outline so that you can follow along and take some notes on them. Um, I like this JPEG because it's well labeled. It's got blue for unoxygenated or deoxygenated blood, red for oxygenated blood, shows you exactly how it flows, vessels, how it comes into the heart, goes to the lungs, and comes back through. So it's important that you understand that. If you need more clarification, I did put a hyperlink to a video that's probably about 15 minutes that goes over that. The next thing that I've given you that should be helpful is actually grouping these deficits. Right now, this may not make sense, but once we go through the four that we're going to talk about, it will make more sense. And then you can say, oh, if this deficit causes this, these are the signs and symptoms I'm going to see. If it's causing this, these are the signs and symptoms I'm going to see. And that will also help you to determine what kind of treatments that we need to do. Now, there's more deficits listed in your book. These are the four we're going to focus on. One resource that I found very helpful was the American Heart Association. They list a lot more deficits, but we are just going to focus on these. So, deficits that increase pulmonary blood flow are PDA, patent ductus arteriosus, and septal defects. We'll talk specifically about ventricular. Deficits that decrease pulmonary blood flow is tetralogy of Fallot. And then deficits that result in obstructed systemic blood flow is coarctation of the aorta. So we've got decreased cardiac output, decreased blood going out to our body. So that should give you some ideas of the signs and symptoms that we're going to see. Okay, so let's start with PDA, patent ductus arteriosus. So we have this ductus arteriosus that is there for fetal circulation because in fetal circulation the baby is getting its oxygenated blood from the mom through the placenta, so the blood doesn't have to go to the lungs and be oxygenated. So there's this little ductus arteriosus from the pulmonary artery that goes straight over to the aorta so that the blood can get circulated. What happens when a baby's born and starts to breathe? We have pressure changes that should close off this ductus arteriosus that usually occurs in the first 2 to 3 days, where this blood is going from the pulmonary artery to the lungs to get oxygenated. It comes back through and then can go out through the aorta and out to the body. But when this stays open and we have the patent ductus arteriosus, then blood's going to flow through the path of least resistance. So I have a lot of pressure in the aorta as compared to my pulmonary artery. So blood's going to move from the aorta into the pulmonary artery. So I've got oxygenated blood that's being diverted from going out to the body. Now some's going to go, but some it's going to go back into the lungs, which means I'm going to have increased blood flow to the lungs. When I have increased blood flow to the lungs, that leads to pulmonary hypertension. I have increased resistance in those lungs because of all this blood flow. And because of that increased blood flow and increased resistance, the heart and lungs have to work harder, and these patients will have signs and symptoms of heart failure. So, clinical manifestations. I'll give you a hint right now. All of these congenital defects all have murmurs. So there's an easy one for you. PDAs have a systolic and diastolic murmur. Now, usually when we hear murmurs, we either hear a systolic or a diastolic murmur. This is one throughout because of the hole, and that is very abnormal. Now, if you're having a hard time with murmurs, at the very end of your outline is a JPEG that talks about where to listen, so your aortic, pulmonic, tricuspid, mitral places to listen, and also a hyperlink to a little 2-minute video that talks about what murmurs sound like, so you can review that. These kiddos are going to have dyspnea, tachycardia, tachypnea, full bounding pulses, those signs and symptoms of heart failure. They may have some intercostal retractions because of the difficulty with breathing because of this excess fluid. They're going to have growth failure. They can't consume enough calories. So we always want to think of our interrelated concepts, and nutrition would be one of those concepts. Because of extra fluid, they're going to be at risk for respiratory infections, pneumonia, and according to American Heart Association, all of these congenital defects are at risk for endocarditis, and we will talk briefly about endocarditis at the very end. So, diagnostic procedures, what are we going to do? These are very common between all of them. We are going to get a chest x-ray. We're going to do an echocardiogram and look at that blood flow, because they'll be able to see the blood flow, and we see blue and red, and it's just like the Doppler that the weatherman talks about, looking at how that moves, and we'll be able to see that we've got that oxygenated blood flowing back to where unoxygenated blood is. They might even do a heart cath. So, what are we going to do to fix this? Because fundamentally for these most congenital defects, we actually have to go in there and fix it. So, there is one medication, indomethacin, which will stimulate closure, so that could be given. They could do a surgical closure, so it's really fairly non-invasive. They just make a really small incision on the left side of the chest and go in there and actually put a little stitch around that ductus arteriosus, or they may put a little clamp in there to help clamp that off. If it's small, they may do what they call watchful waiting and just wait to see if we need to do anything about that. So the prognosis, there's no long-term problems with PDAs if it's treated before I have pulmonary vascular disease develops, that pulmonary hypertension. Once that develops, even if we fix it, those lungs aren't going to be any better. If it's not treated, they will have a shortened lifespan because of pulmonary hypertension. Pulmonary vascular obstructive disease develops. After it's treated, they go on to live a normal, healthy life. Okay, so let's talk about our septal defects, specifically ventricular septal defects. So we have a big septum that runs that separates the right side of the heart from the left side of the heart. Right side of the heart has that unoxygenated blood coming back from the body, going to the lungs. The left side has that oxygenated blood that just went to the lungs, dropped off its CO2, picked up its O2, getting ready to move out to the body. So we'll focus on ventricular septal defects. There are atrial septal defects. I will say that you could have a small atrial septal defect and not even know you have it and get to adulthood and have it found. I have seen that. That can happen because they typically don't have a lot of signs and symptoms. Ventricular defects will have more signs and symptoms, and these are picked up in infancy and childhood. So fundamentally, what is this? This is a hole in the septum between the left ventricle and the right ventricle, which means blood's going to flow from that high pressure of the left ventricle through the hole to the right side of the heart. So I'm going to have oxygenated blood moving from the left ventricle into the right side of the heart. So that's called a left to right shunt because we are moving from low pressure to high pressure. So the shunting of blood is going to cause more blood into the lungs, which means I'm going to have heart failure signs and symptoms. I'm going to have pulmonary hypertension because and I'm going to have a decrease in oxygenated blood being pumped out to the body because that blood's being shunted over. This is the most common congenital heart defect according to your book. So what are these guys going to have? They're going to have a systolic murmur because that left ventricle is pumping during systole. It's squeezing, so we're going to hear that murmur. They're going to have excessive sweating and fatigue during feedings. Feedings are going to be a real trouble because they're really going to have an increased work in breathing and trying to swallow, and we may have to stop feedings a lot to allow them to kind of catch up and kind of let them kind of settle down, get that work of breathing back under control before we feed them. So we always want to think about our interrelated concepts. So nutrition is a big interrelated concept for these. Because of that, they're going to have a lack of growth. They can have or adequate growth, so they'll be behind. They could have frequent respiratory infections. Their tachypnea is only with exercise because at rest they're doing okay, but during exercise, when I need more cardiac output coming out of my heart, more blood flow coming out, I have more demand because I'm exercising, moving around than when I'm sitting. Their heart can't meet that demand because that blood is being shunted over to the right side. They will have some cyanosis, and it is more pronounced with exertion because of that supply and demand. Okay, so diagnostic procedures. These are pretty common for all of the congenital defects as well. So chest x-ray, echocardiogram, doing that echo, watching that blood flow. They might do a heart cath. They could do ABGs if we're having some cyanosis and hypoxemia issues. We could look at a CBC to actually look at to see what their H&H is, make sure that that is okay. We might look at nutritional labs to make sure that we've got good nutrition. So let's talk about how we're going to fix these. So most small ones don't require treatment and can close on their own, and they can close up to about when the child is 6 months. It's pretty conservative treatment if there's no signs of heart failure or pulmonary hypertension. It's just kind of that watchful waiting. Let's just kind of wait to see. If we need to treat them, they can do a patch during the cath lab. So they go into the cath lab just like you would do a heart cath for somebody who we think has coronary artery disease. Poke them either in the groin or usually the groin because that's just the easiest. Take a catheter up there and they'll actually able to do that transcutaneously is what it's called, putting a patch there, or they could do that during surgery. These patients might need prophylaxis for endocarditis as well. That was pretty standard through American Heart for all of these congenital defects, that these patients might need some prophylactic antibiotics for to decrease their chance for developing endocarditis, and we'll talk about endocarditis at the end. Prognosis. Highest risk is for those who have to have surgery within the first few months of life. They do respond well. They catch up with growth. They could have some lifelong tachydysrhythmias, some tachycardia, some SVT, supraventricular tachycardia. So you'll see that in your notes specifically under atrial dysrhythmias. So they could have some of that.